for the pediatric patients. And yes, so I'd like to welcome you, Dr. Sylvia, to continue with this very important topic.
Yeah, thank you, Dr. Karemia. Good afternoon for everyone. Today we are just repeating the chronic kidney disease in children. This topic had been spoken, I think, 3 months ago. The reason we are speaking and talking about renal disease because the diagnosis still not well done. And the children at the time they are referred at Kenyatta or other facility just at the end stage renal disease where we have minimal option to assist the family. So just is to inform other colleagues to be aware about now the renal conditions.
For that, you'll have to turn off aeroplane.
So things. So the learning objective today is just definition, classifications, etiologies of the chronic kidney disease, slight epidemiologies and the clinical manifestations, then followed up by the management. The chronic kidney disease in children is devastating illness with many long-term consequences, just including the disease itself, including nowadays the course of the treatment, complications. So those are the neurodevelopment impact and all the other issues. The etiology and the complication of the chronic kidney disease in children have a major impact on child's growth, neurodevelopmental, and the quality of life. Just you can imagine the child who's supposed to have 2 sessions or 3 sessions for their disease, missing the class, unable to play, so the cost of the families. That's why we are talking about the chronic kidney disease. So most of the children with chronic kidney disease are underdiagnosed because it's very easier for the chronic kidney disease to be misdiagnosed or undertaken with other disease. As we can see, maybe you can see later in the presentation, especially maybe taken by anemia, malnutrition, rickets. So where the people they are not aware about the chronic kidney disease. The clinical manifestation of the CKD in children, it depends on the stage and also it depends on underlying conditions. The definition of the chronic kidney disease, it is just reversible function or structures of the kidney damage which persists more than 3 months, either showed by pathological abnormalities, that's where the nephrologist or interventional radiology do kidney biopsies and they found structural or anatomical changes. Imaging when you do abdominal and the KBA ultrasound, you found the small size of the kidneys. The blood, when now you do urea electrolyte, the creatinine, you found high elevated the creatinine, high urea, maybe hyperkalemia, hypocalcemia, hyperphosphatemia, high PTH, all those complications of the chronic kidney disease. And you don't have abnormality when you found, for example, albuminuria and proteinuria in the urine. And when you calculate the GFR, when you have now GFR less than 60 mils per minute in the duration more than 3 months. So what is the classification of the chronic kidney disease? So the classifications, usually in the pediatrics, we use the KDIGO classifications, which have now 5 classifications. Grade 1 is when you have normal kidney function test with minimal changes in the anatomy of the abnormality in histology, or maybe just slightly elevated the creatinine. So in the way you calculate the GFR, supposed to be above or equal at 90 mils per minute. So stage 2 is when you have now the GFR reduction than expected between 60 and 89. Stage 3A, GFR 45 to 59. Stage 3B, 30 to 44. Then stage 4, GFR at 15 to 29. And the stage 5 is what called now the renal failure. It's just any child who has GFR less than 15 or any child who is on hemodialysis for the duration more than 3 months. What is epidemiology of chronic kidney disease? So epidemiology of the chronic kidney disease in children is not unknown because of the late diagnosis. But you can see now the burden of the chronic kidney disease in the globally, where in 2017, 697.5 million were diagnosed chronic kidney disease, with prevalence of 9.3 1% of the chronic kidney disease. The current epidemiology, the one reported by last year, it's almost now 12% for the whole population. They are suffering from the chronic kidney disease. The global old age prevalence of the chronic kidney disease was increased to 29.3 since 1990. So you can see now the burden of the chronic kidney disease, and especially all other non-communicable disease. The chronic kidney disease resulted in 35.8 million deaths in 2017, and the same year, 1.2 million people died because of chronic kidney disease. So the most common cause of the deaths in CKD is cardiovascular abnormality, especially left ventricular hypertrophy and the dilated and hypertensive cardiomyopathy, and of course, atherosclerosis and death. The global old age mortality rate from CKD increased 41.5% between 1990 and 2017. You can see now the impact of the chronic kidney disease in our societies. As I said, the prevalence of chronic kidney disease in children is not well known. The reason is because of the late diagnosis. And maybe in some countries like Italy, they have now 74.5 children per million of the populations. France, 7.5 children per million of the population. Japan, 3 to 5 children per million of population. So the incidence for the children with the chronic kidney disease is not well known all over the world, not even in Africa. Let's look about now the etiology of the chronic kidney disease in children. So when you look about there are so many factors. I can say it's multifactorial, and you have so many causes for the chronic kidney disease in children. That's why once you have now one with the story, we support to have high index of suspicions. So the most commonly reported chronic kidney disease in children is the congenital anomaly of the kidney and urinary tract, what's called KNH-UoN. So in this scenario, we can talk about renogenesis when you have now the absence of the kidneys, polycystic kidney disease, vesical electro refluxes, posterior valve refluxes, or the ectopic kidneys. Those, they account to more than 45%, sometimes 60% of the chronic kidney disease in children. So you can talk about also infections like glomerulonephritis, hemolytic uremic syndromes. Some of them can be associated by hereditary, like polycystic kidney disease, again, Alport syndrome, which is affecting now the collagen 4. You can have systemic infection like HIV, hepatitis B, lupus, sarcoidosis. You can have other congenital anomaly like spina bifida, Cronberry syndrome, Fanconi syndromes, so which also tend to increase nowadays. Abnormality in the kidneys, spina bifida and the Cronberry syndrome, they are associated by the poor voiding system for the bladder. You can have also reduction in number for the nephro, especially for the children who are born with low above weight in the small gestational age, because the number of the nephro are reduced and they can't generate the new kidneys. So they tend to have the chronic kidney disease and the other other metabolic syndrome disease like hypertension, diabetics, and atherosclerosis. Also, you have also in a couple of the glomerular disease like congenital nephrotic syndromes, steroid resistance nephrotic syndrome, and all other glomerulonephritis. So when this is the one example, for example, the chronic kidney disease in Sudan and the chronic kidney disease in Pakistan. So for example, in Sudan, the glomerulopathies represent 27.5%, congenital urological abnormality 20.80%, urolithiasis 7.7%, hereditary nephropathy 11.3%, systemic disease 5%, and so on. When it come back, for example, in Pakistan, for now the congenital anomaly of the kidney and urinary tract, it was 49%. That grouping now vesicular valve reflux, obstructive uropathy, and those one they have now when the urinary tract infections. So you can have now maybe let's speak about the urinary tract infection, how it causes chronic kidney disease. When the child has urinary tract infections more than 2 to 3 times, it causes now the scanning of the kidneys. Then later on they have hypertrophy and hyperfiltrations. And as long as the number of the nephro reductions, the child may develop chronic kidney disease later in his or her life. So you can have also hypoplastic dysplastic kidney disease, where they have now this percentage, and stony disease, stick disease, and also they have now this glomerular disease where you found these numbers. So the etiology might be variable depending on the region, also how also the people they were able to screen, and also depending also the other comorbidities. What is now the clinical manifestation of the chronic kidney disease in children? Sometimes it can be non-specific, or the other clinical manifestation of the chronic kidney disease might be depending on the stage and the complication of the chronic kidney disease. So some of them you can see by eyes, other one you need to do some parameters, maybe measure the blood pressure, do ultrasound, do your scalitations, at least your basic examinations, maybe your lab, to know what is underlying condition. So for the skin, you can find maybe the dry brittle hairs and the nails, dry skin. The some children they come with the pruritus. That's usually the complication associated by the urea. In the respiratory system, the child may present either tachypnea, deep acidotic breathing, desaturation, and the claricose when the child has fluid overload. And this one usually they present at the end stage renal disease. In the renal, you can have decreased urinary output, especially for the obstructive uropathy or end-stage renal disease. You can have azotemia, that's the urea above 30 when you do your UECs, like UECs, proteinuria when you do urinalysis, and the hematuria. So that's when you can find in the urine. Also for the renal, you can have also anemia, which also associated, even if it is now in the cardiovascular, it is also a marker for the inflammations and the reduction of the kidney nephrons, because the erythropoietin, which is supposed to be synthesized by the renal, it is deficient when you have the chronic kidney disease. So when it comes for the gastrointestinal system and the growth, the child, some children may manifest with anorexia, nausea, vomiting, poor appetite. They have a metallic state, they have a bleeding, tenderness, and usually for the growth, they are stunting. In fact, most of our patients we saw in our facilities, the first clinical manifestation of chronic kidney disease is poor weight gain and stunting. In the cardiovascular systems, so some children may manifest with hypertension. The other one with sign of the fluid overload, they have pedoedema, mind ascites, the sign of the left ventricular hypertrophy, maybe one of those secretion you can find nowadays, the gallopolysis, some of the come with the sign of the heart failure, tachypnea, dyspnea, orthostatic orthopnea, I'm sorry. So lower limb edema and ascites, those are the manifestations you can find for the cardiovascular systems. So in terms of the immune systems, they tend to have lower immune systems, and they tend to have the recurrent infections because the rates decrease the bone marrow responses. And in the musculoskeletal systems, the most common finding will be renal cell dystrophy. That's where you find the child with bone deformities, short status. So, or either the child can manifest with the pathological fractures because of the lower calcium, lower vitamin D, and hyperphosphatemia. In terms of the hematological, you can find the child has pallor, has fatigue, and sometimes they can have a thrombocytopenia, which we did now the bleeding tenderness, maybe at the puncture site. And in terms of the neurological, so it depends on the severity and the stage. In the latest stage, the children will have at least the peripheral neuropathy, lethargy. Some of them they can present with the confusions. Other one they can present with the encephalopathy, either secondary to the uremic encephalopathy, or either secondary to the electrolyte imbalance, like for example, hypocalcemia or hypernatremia, or either secondary to the severe hypertension. So this one of the sample which was done in one of the hospital, where there was just checking the clinical manifestation of the children with the chronic kidney disease. So when you look about now this table, you will find, for example, this is the number of the children who have been screened, and you can see them at the stage 1, 2, until now stage 4 and the stage 5. When you look about now, for example, now the growth failure, So that's the Europe, and that will be different from our setting. But you can see the growth factor is just increased from 6.7, then at 46.6 at stage 4 to stage 5. So anemia, which is among the most common is severe complication, at stage 1, all this at 1.2, they have anemia. This anemia can just go increasing, and you can find at stage 4, stage 5, this 93.3. So bone and mineral disease, 6.2 at stage 1, then it increasing until 100% in stage 4 to stage 5. Hypertension, it's area sign of hypertension. As you can see, in stage 1, you have 63%, and at around 80% in stage 4 to stage 5. As the one, you can find the metabolic acidosis, which is also increasing according to the stage, and electrolyte abnormality, where you have now hyperkalemia, which is lower side at stage 1, then increasing at stage 5. So proteinuria, usually measure about what called microalbuminuria of 5.8 at stage 1, then at 40 at stage 4 to stage 5. You can find all those manifestations, the clinical complications, with increasing with time. So earlier screening and the earlier intervention may delay and may slow the progression of the chronic kidney disease. That's why we are trying to advocate for the children with the chronic kidney disease. This is the sample of some of my patients I saw here in Kenyatta National Hospital. You can look at this gentleman, how this boy do legs. So you can see this another child with now these the clinical features, the bone deformities. So this child has higher uric acid, more than 400. So has both gout and both the bone deformities. So this is another child where we are showing now this the X-rays. This child has chronic kidney disease connected to the obstructive uropathy. You can see the bilateral nephrostomy, and then stage 5 hydronephrosis. You can see how the bone was deformed. This is another child. You can see how this child has 10 years. You can see, look as child who has 4 years with short statures. This is another child you found on oxygen with severe pallor. Those are the some clinical manifestations we get from our patients. So that's why we support to always to check about the chronic kidney disease with high index of suspicions, and also not to forget so other cause, so that you can treat in globally all the children conditions. So we are now starting for the treatment for the chronic kidney disease. Stage 1 is how we can treat reversible kidney conditions, maybe avoid the nephrotoxic drugs like aminoglycoside, non-steroidal anti-inflammatory drugs, the cyclosporine, the drug like, for example, CNI inhibitor support to monitor, that's cyclosporine, tacrolimus, for those children who attended maybe rheumatology clinic and SLA, systemic lupus and lupus nephritis in the renal clinic. Those are the channels we support to always put on our eyes and monitor tacrolimus or cyclosporine levels, and make sure the creatinine is not rising. For aminoglycoside, and we support to reduce as soon as possible, apart if it is only one drug indicated and sensitive for the culture. And for the radiocontrast nephropathy, when the child requires maybe any investigation, and we are advocating to perfuse the child before and prior that investigations. We give the fluid the 1 day prior, and we give the fluid when the child comes from the CT scan with the contrast. So always we prevent and treat dehydration, especially for the children who has acute gastroenteritis or the blood loss secondary to road traffic accident, and we treat obstructive uropathy for those one has maybe post-irritable valve reflux. We work together with pediatric surgeon, urologists, so that we can improve now their urine output, and we care for those children. So the second step for the treatment is how we can slow down the progression of the chronic kidney disease. So it requires to intervene at the early stages to prevent additional loss of the nephrons and decline of the kidney functions. So one of the methods that have been successfully, especially in the adult populations, is how you can now blockade the renin-angiotensin aldosterone systems So this one, it has been helpful to reduce proteinuria in chronic kidney disease. So I use ACE inhibitors and the ARBs. The recommendation is where you start at stage 2 to stage 3. And when you find, for example, the creatinine increasing more than 30% after starting ARBs or the ACE inhibitors, it's recommended to stop the treatment. So it's better to blood pressure control for the children who has hypertension, even if they don't have chronic kidney disease. For the one who has chronic kidney disease, you are targeting at least minimum 90 percentile, and if possible, 50 percentile. So the blood pressure control is, you are just now the counseling for the child, the families, use now medication, also non-pharmaceutic, like the diet, where you're supposed to reduce salt, not taking a lot of fluid. So also proteinuria reduction by reducing protein intake, and of course using now the ACE inhibitors, ARBs. Strict glycemic control in children with the diabetics mellitus. That's where you support work together with endocrinologists, with nutritionists, with successful treatment. So as I said, dietary protein restriction for the one with the chronic kidney disease, and also remember to treat other comorbidity adequately. In this stage, whatever medication you plan, it's required to have a good counseling for the children, and at the same time for the families, at least to understanding now the pathophysiology of all the complications and how the journey will be working together with them, how you assess them. And it's better to give them your phone, and in some cases they can consult you if there is anything happens. So this one is this table, I think you saw it. So we treat now the complications. I don't need to repeat this table. So we look at least one of it by one, how we can treat those complications. So the anemia, it's the most common complications is the bone mineral disorder. The prevalence of anemia increases as CKD stage also is advances. And the children with GFR less than 30 mils per minute have 4 times the risk to increase anemia than the children with CKD at GFR of 50 mils per minute. So you can just a small reduction of 20 mils per minute, increasing in the anemia 4 times. So they say now anemia can be present at 73% at stage 3 and 87% at stage 5 of the chronic kidney disease. And sometimes, as we saw in that figures, it can go even more at 93%. So anemia increases the risk of hospitalizations, the development and the progression of the left ventricular hypertrophy, congestive heart failure, and death. So the mechanism of it, if the child has anemia, so it's supposed to be now compensating by the increasing the heart rate, increasing now the stretching of the cardiac muscles, reduction of the perfusion of the kidneys. Then you have anemia and the cardiorenal syndrome, where you have all the complications. You have renal issues, and then have heart issues. And if you are unable to correct the anemia, the chronic kidney disease worsens very fast, and you end up for the chronic heart disease. So this is a WHO definition of anemia in children according to the age. At least now, this for the clinicians, you can remember this table. A child at 6 months to 5 years, at least hemoglobin less than 11 is considered anemia. The same between 5 and 12, 11.5 grams per deciliter. And the children between 12 and 15 years, if hemoglobin is less than 12, is considered anemia. And in above 15 in male, hemoglobin less than 13 is considered anemia. In the female, when hemoglobin is less than 12 for the female above 15 years. So always you check your full hemograms, you check your reticulocyte count, you check your ferritin levels, check serum transferrin saturation, which is not usually done in our lab. You check also other comorbidity like serum vitamin B12 and folate levels. Also, you minimize your blood loss by by taking the small sample, so that's at least how we can try to overcome this anemia. So the treatment of anemia, it's not very easy as we think, because the normal diet sometimes is contraindicated in chronic kidney disease, maybe because it has higher phosphate intake, but we try to see how we can help the children. So some children may require blood transfusions, other one may require maybe oral or IV iron sucrose, so other may require erythropoietin stimulating agent. So for oral, we can give now in oral children with chronic kidney disease, not on erythropoietin stimulating agent, oral iron or IV iron is recommended when transferrin saturation is less than 20% and the ferritin level is less than 100 nanogram per ml. So at least ferritin level, our lab can do it, and most of the lab can perform it. That can be at least the first in this, at least to guide us how we can start now the medications. Pediatric chronic kidney disease patients on erythropoietin stimulating agent therapy who are not receiving iron supplementation or oral or IV iron administration to maintain a transferrin saturation 20% and the ferritin support to maintain at 100 nanogram per ml. So that's why you're supposed to start at least to maintain above those levels. So usually we can start in the pediatrics, we can start maybe the serum ferrous, you can start using the folate, also can give a lanthanum. So always just to combine and to check now their adherence, because sometimes so can reduce the appetite for the children. It is not easy to treat the children because also other factors are interfering. So most of the children, of course, we start on erythropoietin because the deficient, and the key point for anemia in chronic kidney disease is lack of or inadequate production of erythropoietin. So the benefit of erythropoietins is reducing now the number of blood transfusions. But however, one of the complications is increasing now the stroke, vascular access loss for the one on hemodialysis, and sometimes may increase now the hypertensions. So the recommendation to stop now erythropoietin stimulating agents if no raise for one hemoglobin, at least hemoglobin within 1 month when you started. But take now the notes if the child has issue with maybe any other disease at the time you start erythropoietin, or the child has any bleeding of the child, so you suppose not to stop erythropoietin because you think the child had been lost the blood or they was not eating well. So you consider now if there's no loss of hemoglobin in 1 month for the children who is stable, not the one who is unstable. So there is now the current one we are using is the erythropoietin. Elsewhere they can use another drug called dapapain, which is not available in our setting. So the doses are different. So the dose is just between 275 to 300 units per kilo per week. The maximum is 400 international units per kilo per week. And in big children, you can start at 200 to 250 units per kilo per week for older children. But all of them, so whatever it is infant, whatever it is the big children, the target, the maximum we can go beyond is 400 international units per kilo per week. So our target hemoglobin usually for the small children 10 to 11 and maximum 12.5 grams per deciliter. So when hemoglobin is above 12.5 gram per deciliter, we try to stop or to reduce or taper down erythropoietins to reduce those other complications. So some children also may require the blood transfusions, especially when they have symptomatic anemia, when also they have, for example, my disease like hemoglobinopathy, for example, the one who has maybe sickle cell disease associated with chronic kidney disease, and they have low hemoglobin levels. So if the child has bone marrow failure, when you do reticulocyte count or bone marrow, if they have the reactive bone marrow, or if the child has now resistance or no, a erythropoietin stimulating agent, you need to give it the blood, or if there has anemia with complication, or where there's contraindication of the erythropoietin submitting agents, especially in malignancy, where the patient has a recent stroke. So always remember to talk about and advocating to have now the balanced diet, where you're supposed also to talk about the vitamins in the supplement vitamin D, supplement vitamin E, folic acid, and the L-carnitine levels. So usually always you consider how the patient look like, how the availability to get the blood, how availability to get another mode of the treatment. And as the time you are waiting, maybe to get the blood, if someone stay far, you can start on erythropoietin, you can start another, either for example, iron, sucrose, IV, and then you refer the patient if you are unable to get the blood. So another complication we need to manage is hypertension. So hypertension, as you saw, is started earlier. At stage 1, we found more than 50% of the children they have hypertension. So in increasing risk for mortality, morbidity in children with the chronic kidney disease, that's increasing now left ventricular hypertrophy, increasing congestive heart failure, increasing the stroke. So hypertension is supposed to be treated now adequately, and you're supposed to target now at 50% as I said above. So you consider the cause of the chronic kidney disease. Also, once you treat them, sometimes the blood pressure may improve. That is an example for the children who have obstructive uropathy. You can consult a virologist, pediatric surgeon. They can do ablation of the posterior valve reflex. They can fix and insert the stent. Also, sometimes they can do urinary deviation by cystostomy, by erythrostomy. And in that time, once you reduce the pressure from the kidney, also the blood pressure may always improve. So always consider underlying condition, treat them. Then you also treat hypertension. So ACE inhibitors, these are usually indicated for the first line to slow the progression of the chronic kidney disease. And as I said above, if you start on ACE inhibitors on the ARBs and you found the creatinine is increasing more than 30%, you're supposed to stop and are not indicated in stage 5. So you don't use any ARBs and the ACEs inhibitors in stage 5 of the chronic kidney disease. So other group of antihypertensive drug you can use beta blocker, you can use the diuretic. The diuretic you use only for the patient who can produce urine. If the patient is anuric, there's no need to use the diuretic. So you can use the vasodilator, you can use the calcium channels blocker. So those are the drugs you can use. And sometimes you can use the central antihypertensive drugs. So there is a lot of the diet, there's a lot of the lifestyle modification, the child is supposed to do exercise. So you increase the green despite now increasing your potassium levels. So there is a way we try at least to do the minimum level to reduce the blood pressure. However, it's not easy to treat hypertension in the children because some children may require, for example, 4 or 5 combinations of the drugs, where you can have, for example, alpha and beta blocker in combinations. You have 2 diuretic, you have 1 calcium channels blocker, and you have, for example, vasodilator. So all the combinations are required, and you look about now the complication of each drugs, the drug interactions, and also the side effect of each drug you are prescribed for your children. So the bone mineral disorder in chronic kidney disease, it's almost 100% at stage 5, and you support to treat and try your best how you can at least reduce now these harmful complications. So usually dystrophy is impact of the disease on the skeletal system. That's by the definitions. And the term, then bone mineral disease also affect cardiovascular systems. In which way? Because for the bone mineral disorder, the key point is a reduction of the flow of the kidneys, and at the same time, there's now reduction of the excretion of the phosphate. So you have now hyperphosphatemia, and also there is another element called the clotho and the fibrous growth factors 23. In all those ones, they also increasing nowadays, the worsening nowadays, the issue concerning the calcium absorptions. And at the same time, you have now the vitamin D active form 125 deficiency. You are not able to absorb your calcium levels in the intestines. And you have now a complex, you have a lower vitamin D, higher phosphate, and then lower calcium. You may have secondary hyperparathyroidism, and you have all other complications. So it's better to start the treatment earlier and to monitor the progressions. So the clinical symptoms usually start at stage 3 of chronic kidney disease and worsen when the progression of the chronic kidney disease worsen from stage 3 to stage 4 or stage 5. So the skeletal deformities, that's what you found most of the times in short statures. You found also the pathological fractures. You can have found the muscular and the bone pain, which they may present, maybe which can mimic with the osteomyelitis, or maybe with the acute lymphoblastic leukemia, and some children may have a vascular necrosis of the head of the femurs. That's where you support to measure both legs to find if they are E. coli, and also, of course, the growth failure because now the diffusion of the epiphysis area stages. So how we do investigation? We check the serum calcium and the phosphate levels. We check serum magnesium, vitamin D, serum PTH, direct phosphatase. Sometimes can do imaging for the bones. We found now the bone deformities. And so in the advanced country, they can do a bone density. This way they can measure bone density. And at the same time, they can do now the biopsy of the bones, which we don't alive at that stages. So how we manage now the bone mineral disorder? Always equate calcium if symptomatic. So you give now calcium gluconate IV. The dose 30 to 60 milligrams per kilo per day. Also can give oral supplementations, and the always calculate adequate dose, because most of the oral supplementation you may find 150 milligrams for elementary calcium either in 5 ml of the solution. So you adjust the dose according to the daily requirement of the calcium. So you can give now vitamin D, either IM or oral vitamin D. And also remember to binding now the hyperphosphatemia. So we can bind with either calcimimetic, where you use now, sorry for the writing, we can use now actotams, which calcium carbonate. So also can use sevalama. In the time you have now the lower calcium and the normal phosphate. So this is for the dosing for calciferol and vitamin D deficiency. So if, for example, now this is according to the severity, when you measure now vitamin 25 and is less than 5 nanogram per mils, so you give now 80,000 international units per day or 50,000 international units per week. This one per week for 4 weeks. Then you give 4,000 international units per day for 8 weeks. So either the duration usually is for the 3 months, and you measure now vitamin D levels after 3 months. For the mild vitamin D deficiency between 15 to 12, to 15 nanogram per mils, you give 4,000 international units per day, or either 50,000 international units every 2 weeks. The duration for 3 months, and the one who had the mild vitamin D deficiency, 16 to 30, you give it 2,000 international units per day, per oral, for the duration for 3 months. So most of our formulation of vitamin D, they have, I found the one on the market which has 2,000 international units, but most of them may have either 400 or either 800 international units. So it's as now the clinician to adjust and to give adequate dose for therapy, and you monitor now the vitamin D3 levels. So always remember to treat also the magnesium, because it's a cofactor of calcium. If it is 0, the dose of magnesium will be now 30 to 50 milligrams per kilo per dose twice per day. So we look about now the nutrition. So here we talk about the protein energy wasting in chronic kidney disease or stunting. So where you have the comorbidity, which is now chronic kidney disease, you have the dialysis, where you remove now the nutrient by the machines. So the child will have now anorexia connected to the urea. You have a decrease in nitrate intake because of the overload, maybe nitrate insufficient because of the poverty. You have energy expenditure because now the kidney is the high catabolic state in disease. You have insulin resistance in chronic kidney because chronic kidney disease is inflammatory disease. Also, you have growth hormone resistance and inadequacy where it's supposed to give now extra growth hormones. Either you have lower testosterone levels, which support to be increased the growth. And of course, you have persistent metabolic acidosis, chronic inflammations, and oxidative stress. All those complications, all those events. So the increasing now the risk to get now the protein energy wasting in chronic kidney disease. So by definition, growth failure is defined by as hate for age below than 30% type. So for the normal curve where you consider now the children by gender and by age. Most of the children have short statures, but in our setting, most of them, more than 90% have short statures, and the growth failure increasing progression of the chronic kidney disease, if you remember that tables, and the risk of death increased by 14 for each minus standard deviation score decrease in height. So you can see for the child now has a -3, that the mortality will increase now at 52. So that's why we support to work together with the parent, with the nutritionist, with other, maybe even the teacher in the primary school, secondary school, how we can sustain now the children in the chronic kidney disease. So adequate nutrition is a pillar in treatment of chronic kidney disease, and you are difficult to get nowadays, usually the normal calorie intake, but reduce the protein because of the proteinuria and higher phosphate support to avoid. This role of a nutritionist review and the nutritionist assistance. So maybe in a big hospital, you are lucky because you have the good nutritionists who know, who are aware about the chronic kidney disease. So they really help for those children. They really help when sometimes they can go in the kitchen, requesting specific food for each child, and that has really helped to sustain the life of the children with chronic kidney disease. So you avoid and reduce phosphate intake, so especially fast food, which is we bought in the supermarket, they are very rich in phosphate. Most of the conservative food, they are very rich in phosphate. We're supposed to avoid that the maximum levels. So always lower potassium intake and normal calorie intake according to the weight and according to the age. So we try to reduce the lower salt and the fluid restriction because to reduce now the risk of the fluid overload and to control the blood pressure. So optimization of the dialysis, which is not achieved because most of the parents, they cannot afford the dialysis. Basically, the child is supposed to receive at least 3 dialysis per week. Unfortunately, because of the lack of the money, we do twice per week. So it's not adequate for the children, but we are still advocating maybe probably in the future, we may achieve this target. So also we can give human a growth hormone for the children before now this epiphysis fusion of the growth. This is one of the table where we say how now the combined dietary protein intake for the children, the chronic kidney disease between stage 3 and stage 5. So you can see between 0.01 at above 2 to 6 months. So you can use now the between 1.5 grams per kilos. And as the child grows, you increase now the requirement. And if the child is no peritoneal dialysis, you may increase the dose because the peritoneal dialysis remove a lot of proteins. So I think this table may be useful sorry for it, may be useful for the nutritionist and for other people who are just handling now children the chronic kidney disease. But as you can see, there is at least the requirement for each child according to the weight and according to the age. And you see, according to the compensations of the activities and the losses from the physical and the other energy expenditures. So we have now another complications, chronic metabolic acidosis. The chronic metabolic acidosis has been also difficult to control because we don't have the available sodium bicarbonate easier in the hospital, even in the pharmacy. It will be difficult, it has been difficult for us to achieve the target. So the chronic kidney disease is associated with metabolic acidosis. So, and that's the complications. So it can cause now enhanced production of the beta microglobulin, which is now the proteins. So chronic metabolic reduce now albumin synthesis, which lower albumin levels. And when you have lower albumin levels, you have lower calcium. When you have lower calcium, you have lower magnesium. You can see now the event you have. It increasing now the mass of things. So you have also access to the progression of the chronic kidney disease. And so it impairs glucose tolerance. Also, it has effect for the growth tradition in the children. And also, it is associated by degenerations or exacerbation of the mineral-borne disease. How we do just frequently measure the blood gas analysis aims to have a sodium bicarbonate equal to 22 millimole per liter or above. And the treatment to give sodium bicarbonate, a tablet, we have the tablet of 350, 650, and the 1.5 grams. The dose is 6 milligrams per kilo per dose, and it's supposed to be given 12 hours to 8 hours. So we prescribe that tablet, we measure the blood gas analysis, and most of the children on chronic kidney disease, it's difficult to achieve nowadays bicarbonate of 12 because of the underlying condition. Sometimes they get the disease, either the parent are unable to buy the drugs, either they have the money, they are unable to get it. It's very easier. So it is a complex scenario where we are trying to see how we can sort things out. So another is just the hyperkalemia. So hyperkalemia, you can see, look these pictures. This is our common food, African food. You can see all the seed, all the grain like minji. So you can have waro, you can have ngwashe. So all the greens, the fruits, they are very rich in potassium levels. So it is difficult how you can prepare now this food for the children who have chronic kidney disease. As now you achieved your target and you try now how you can increase now the input. So you can't restrict 100% for the potassium. There's a way you can reduce maybe intake. Then you increase now the potassium excretion by giving now the potassium binder, where you use a kayexolate at 1 gram per kilo per day. So these drugs are given 3 times per day, and you monitor the potassium levels. So the last mode of the treatments is for preparation of the renal replacement therapy. So we have 3 modalities. We have dialysis, we have hemodialysis, and you have kidney transplantations. So if you get the patient earlier, we discuss with the families, and we discuss each modality for the dialysis or each modality for the transplantations. So you get the counselor, for the counseling for the family and for the child. So you're supposed to know how the mentally for the child, because if the child has a mental issue, can't use peritoneal dialysis. So you're supposed to check your coagulation profile, you check now your blood levels, you check your hemodynamic stabilities and economically of the parent. So before you decide which method you will use for the renal replacement therapy. However, most of the patients we saw, they come when they don't have that window to discuss. We're supposed to do emergency dialysis because the child is anuric, has uremic encephalopathy, has rebounding hyperkalemia, has severe metabolic acidosis, had fluid overload, is convulsed because of the hypertension encephalopathy. So you don't have enough time to decide. You save life first, then you come back to discuss with the parent how now we overcome the modality you started. So always once you start now for either peritoneal dialysis or dialysis with the machine, or either we do transplant, we always consider the counseling on adherence of either for peritoneal dialysis, for hemodialysis, or how the patient whom we successfully transplanted will be able to adhere in the compliant on the immunosuppressions to avoid now the kidney injections with the graft. So always also do vaccination to reduce the risk factors of other infections. And to be successfully in each modality used, you support to have and to work as a multidisciplinary team between now the nurses in the ward, the nurses and nephrologists, the nutritionists, the counselor, the surgeon, the anesthetist, the social workers. So it is a multidisciplinary team where if one organ is not working, another one cannot be successful. So the most unity of didn't know which has been successful is when you have now all those teams working together, is where you can have maximum care. So the take-home message of today, so I can say because of the manifesto of the chronic kidney disease in children are variable, and the role of the screening is more important. So always advocate and just inform all the pregnancy mother to do antenatal ultrasound, because some of those congenital abnormalities, they can be discovered during pregnancy, especially for those one associated by obstructions. So we recommend for the KUB ultrasound for any child who had more than 2 episodes of the urinary tract infections, because usually that one is suggesting any congenital anomaly until proven otherwise. So always you consider to consult and refer area to nephrologists who will take care of the children's area as soon as possible. And the management of chronic kidney disease require multidisciplinary team, as I said, and it's only transplantation is successful management for chronic kidney disease. So maybe the people stay far from Kenyatta. Kenyatta can able to do transplant for any child who is above 10 years. From 9 years to 10 years, we are able to do transplant as long as the family can get the donor and financially supported. So don't delay. Where the people they say we are unable to do transplant, we have been done. Me personally, I've served 4 children when I was a student. So in 2019, we transplanted the one child and has been doing well, he improved. So as speaking as per today, there's another one we transplanted the last week on Wednesday, and hopefully we are able to discharge tomorrow. So it has been done well. So there is always a good hope. There's always the better life after transplant. And that's why we support to focus now as the major treatment of chronic kidney disease. Thank you so much. Thank you for your attention.
Thank you, Dr. Syriac, for this very elaborate and informative presentation. I think from this discussion, we've learned that our patients who present with chronic kidney disease come with a myriad of complications, and the key to management is early recognition and management of these complications. I'll go straight to the questions. So our first question is from Said Ahman. The question is, why are we trying to discourage blood transfusion as an option in managing anemia in CKD patients?
So let's I explain it very well. So if there's options, we can avoid the blood transfusions. In a patient with chronic kidney disease, we can avoid it, because you see, when you give now the blood, you are sensitizing for the immune system. So the reason is when you are able to do transplant, the risk of rejection is very high, or either you increase now your immunosuppression to sustain the grafted kidneys. That's one of the reason we are trying to reduce the blood transfusions. There's no other reason. Also, maybe another reason which is common for all pediatric or even for adult, you remember the blood can have also infection like maybe hepatitis B, even if there's the screening, malaria, so can be associated by anaphylactic reaction. Some patients can die. So it is the last solution. It is not the first solution.
Thank you for that. The next question is from Lucy. Would you clarify on high turnover and low turnover bone metabolic disease in renal osteodystrophy?
So those are the complications of the chronic kidney disease, which come for the bone and mineral disorder. So you have now two terms, say high turnover and low turnover. So high turnover is when you have now the child who have a chronic kidney disease and they have now the lower vitamin D3 levels, which increase now, it decreases lower calcium absorptions, and you have now the complex of the hyperphosphatemia, lower vitamin D, and as consequently, you have secondary hyperthyroidism. So that is now high turnover, and that one is usually associated by the so many complications. So lower turnover is when you have now, for example, maybe one complications, you have initially lower vitamin D, and you don't have the severe complications, you can treat with the vitamin D levels, already you have lower calcium levels, but not severe or not secondary hyperthyroidism. So that one is usually the lower turnover of bone mineral disorder.
The next question I'll combine is from Samuel and Peter. What are the cost implications of transplantation to the family and the cost of the drugs? So like an average cost of transplants.
So it says, what are the cost implications of transplantation? Okay, so the transplantation is quite expensive because if someone has lucky where you have the first donor skin is having all the requirements, you don't choose another second donor. So at least the preliminary investigation can cost between 250 and 300,000. Those only investigations before transplant. For the transplant, NHIF is sustaining 500,000. And the operation of the transplant can cost almost 1 million. It's meaning at least the family is supposed to get another extra 500,000. So then the immunosuppression for the children in NHIF will pay for 1 year, which is free. But if you don't have now, you are unable to fulfill all the requirements, you will pay yourself. So for the first year, usually it costs randomly around 40,000 per month. However, when you look about now, those money fund, it is a lot of money. But when you look and you compare with the hemodialysis, it's very cheaper. Because when you look about, for example, hemodialysis, it is cost 9,000 per session, which will be 18,000 per week. Then times 2, which is 72,000 per month. It is almost around 870,000 per year. So in that one, if you sustain for 3 years, so you have almost 3 million because you are account about also the transport and the lack of water. So even if it is expensive, it's a better option than hemodialysis. Then also the quality of the life will be changed. The child can come back to school, so can enjoy his or her normal life.
Thank you for that response. The other question is from Paul. Is CKD curable?
So by definition, maybe let's start by definition. When you say the patient has a chronic kidney disease, it's reversible. However, if the person is able to do transplant, we can't say it's curable, but you can monitor the progression and you can have better outcomes. So I can give him an example. When I was a student in postgraduate in 2014, the second person I met and I fixed a hemodialysis catheter was an engineer. In 2018, when I went at Mombasa, for the Kenya Renal Association conference. I meet with that person. I'm telling you, was just wonderful, and it was surprising to find the person who was almost gasping. Now he's able to talk, is able to come and witness how the journey was. So it's not a curable, of course, because you still need the drug after transplantations, immunosuppression, but at least you can come back to your normal life. Your creatinine can be becoming better, and sometimes, in almost most of the time, to be normal. You don't have medication for acidosis, so you don't have issue concerning the anemia and the severe hypertension, apart if you have underlying conditions associated. So it's not a curable, but you can improve the better, the quality of life, and the self-esteem for the patient after transplantations.
Thank you for that. What is the role of PMSA scan, and how do low result centers miss out on prompt diagnosis due to lack of such advanced tests?
Okay, so the test DMC scan we use for the children who have suffering from urinary tract infections. So it show for the imaging will show the scar, and if you have the scar, it can predict nowadays in the future the risk to develop chronic kidney disease, because any scar is meaning there is a number of the nephrolosis. So, however, also the machine can measure also the estimated glomerular filtration rate. Once you do DMC scan, we are targeting to see the scar of the kidneys, that at the same time it's estimating now the GFR. Indication is the patient who has recurrent urinary tract infections, the patient who suffered the acute pyelonephritis. So now, if you are unable to get now DMC scans, so you are unable to know now what's happening from the kidneys. So only the level you can use, check your urinalysis to check if there's no leukosturia, if there's no nitrate, if there is no protein in the urine, because always the urine is the window of the kidneys, and always at least measure your creatinine levels. However, the creatinine level cannot exclude out maybe any anomaly or non-functional one kidneys. That's why you need to do DMCR scanning for the patient who have recurrent urinary tract infections to know the scarring for the kidneys and the anatomy of both kidneys.
Thank you. After the transplant, how frequent is the child supposed to come for checkup, and for how long?
Okay, so there is a protocol for post-transplant. For the after transplantation, the patient is supposed to come weekly, at least for 2 months, to assess the kidney function test, and to assess if the blood pressure, to assess hemoglobin level, to see if now the graft site is not, there's no any infections. So this one is just every week, at least for 2 months. Then later, twice per week, then once per month. So basically for life, the patient will come at least once per month. If the patient phone is compliant, he can come every 3 months. But that one is supposed to know if the patient has good compliance and a good adherence to medications. And you're supposed to communicate with him at least or her, and if the parent at least to do baseline, at least the urinalysis, and he sees at the nearest facility if they are unable to come within that period of the 1 month. So the follow-up is follow-over. So the patient will still need to be come back always in the clinic to be checked now the blood pressure, to check the random blood sugar, to screen for the infections, and to see now the urinalysis in the urea extract and the creatinine levels.
The next question is from Lloyd. Do you find non-compliance of post-transplant medications in children an issue?
Yeah, so that is the most common in teenager and adolescent. That's the big issue for the children. It's when now they achieve now the adolescent. For the adolescent, I think all the children, apart only the one child we transplanted in 2014 from Uganda, is the one I never found any non-compliance. But all other children transplanted, the one in 2014, and the one transplanted in 2019, all of them, they had non-compliance. So especially in adolescents. So they try to avoid and escape some of drugs, especially prednisones, or either tacrolimus or cyclosporins. This is the most common, and most of them were admitted. They have been readmitted after kidney rejections, given some drugs. Then we focus with the counseling again and again. So it's more common in pediatrics. Issue is just adolescents issues.
This is a question from an anonymous attendee. Great presentation. What is the Renal Association handling advocacy in relation to renal transplant, especially cadaveric transplant?
So the current information I know, because I'm not informal at 100%, but the last month I had opportunity to meet with the chair, the coordinator of the task force, which will be related by what called now tissue donation, which is including now the blood transfusions, kidney transplant, cornea, and the liver transplant. So there is a rule in the parliament. The parliament has been approved. The parliament of the Kenya approved now that rules. So, however, some regulations they are supposed to be put in place to make sure the delivery of the cadaveric kidneys and the other tissues following up nowadays as the requirement, and the priority for the small children, of course, and also if there is no where the people they can do the bribe, where maybe the kidney can be donated by the very rich family. There's those regulations which I think are one of our team leader, Dr. Njije, the Dr. Ahmed Twahir, they are still fulfilling those issues. And soon we expect now to have all regulations. And once we have now the cadaveric, we can just maybe transplant so many people as possible.
Thank you for that information. The next question is from Daniel. Why is it that in stage 3, the complication due to hypertension rate is 81%, while stage 4 to 5, the rate is reduces to 80%?
Okay, so I think it really depends on the studies, because you see when we publish the study, when we discuss now in maybe in this discussion or other discussions, we tend to use maybe one study or another studies. It's not a meaning when I took this study is representative of the other studies, but with my experience, all children with chronic kidney disease, they have hypertension, and is not reducing by stage. So once the child go to stage 4 to stage 5, in fact, the blood pressure becomes very severe and difficult to control. However, this maybe for this study, the reason the blood pressure was low at stage 4 to stage 5, it's because initially you can discover the patient at stage 3 or stage 2 with hypertensions and without the treatment. Then once we give now the treatment, the severity of the blood pressure will be controlled. But basically the blood pressure will increase according to the stage of the kidneys. And how I can explain is when the number of the nephro are reduced, there is increasing hyperfiltration of the kidneys and hypertrophy of the kidneys and increased renin-angiotensin aldosterone systems. So in that one, you worsen it by each stage. So normally at stage 4, stage 5, the blood pressure is very high and difficult to control than stage 3. So this one is the study done elsewhere, but it's not reflecting all the children with chronic kidney disease, and they cannot reflect even for our children we saw at Kenyatta National Hospital.
So this again is related to transplant. So one, will the kidney that has been transplanted eventually fail? And then is there a possibility that after the transplant, the child can complicate and die? And if, in terms of the donor, if in a pediatric case, the donor is an adult, what is the success rate so far?
So the start for maybe the first patients, you can have rejections, maybe acute rejection, because that one is a big topic which I cannot answer exactly in short period. Because when you talk about acute kidney rejection after transplant, there are so many factors. So this is how operation has been done when you take down the kidney code now, the cold ischemia and warm ischemia. So cold ischemia is the time now the kidney was in the fridge, and the warm ischemia is the time now the cardiovascular surgeon, they did anastomosis, they donated the kidney to the blood vessels. So all those ones, if they are prolonged, cold ischemia more than 24 hours, it increases the risk of factor of the acute rejections. So other factor maybe can be maybe the drugs. So you are not using the drugs, maybe lower immunosuppressions, so the patient can have rejections. Maybe you have maybe thrombosis of the donated kidneys can cause rejections. Maybe the bleeding can cause rejections. Either infection called the Bika virus, maybe HIV, cytomegalovirus, tuberculosis, those one can cause rejection. However, the how we do kidney transplant, I don't know if the one who asked this question is aware how we do transplant. When you do kidney transplant, it is long journey where we screen all those scenarios, infections, the patterns of the kidneys for both the donor and the recipient. The blood sample will be done, imaging will be done, and at the day for the transplant, even or the following day for the transplant, all sample will be taken at the right time. In fact, we take the sample every 4 hours. So we have to measure now the kidney function test, liver function test, electrolyte, hemoglobin, all those one we measure within 4 hours for all the 1 week. So, and also we give immunosuppression according to the what called the cross matching. So it's unlikely to have rejections. And if it's occurred, so there is another way we treat. We give now the immunosuppression like bacillizumab or metaprednisolone. So me personally, I never found any patient who had acute rejection within the first month, and we lost the graft. It's very rare, very rare. So with a period I stay in Kenyatta, so maybe one person has rejections, and we're able to treat and improve, and that one was the adult, not for the children. So for the children, the successful, the children after kidney transplant, they are getting better than in the adult. So they improve very fast. Their weight, their height, the blood sugar, the blood pressure, it improves very fast than adult. So the kidney transplant is more successful in children than adult because so they don't have so many other complications or other comorbidities.
Thank you for that. I'll finish with this last question. Is there an effect of dialysis, that is repeated dialysis, on eligibility of patient getting a kidney transplant?
So, I don't know how I can explain. Okay, so for when you do the protocol for the transplant, when you do the protocol for the transplant, so there's when the patient is admitted, so there's what is supposed to be done in terms of the monitoring for the vital signs, screening for infections, and the dialysis. So we do, usually the patient is admitted either on Tuesday or Wednesday, just 1 week before or prior for the kidney transplant. So we do transplant, we do dialysis on alternate days, and the last dialysis usually it's done on Tuesday when the patient will go on in dialysis on Wednesday. However, if patient failed, as the one of previous question, if the patient has now the rejection, acute rejections, that patient can come back to hemodialysis, while now the clinician will still giving the immunosuppression to sustain the grafted kidneys. That's how I can explain. But usually, for the patient who respond well on transplant, especially for the children, I never saw any child we return back for hemodialysis after kidney transplant. All of them, they are cooperating well, they are coping well, they improve very well with transplant. But in the adult, I saw some few patients who have been coming back to do hemodialysis after transplant, and most of them, they are not associated by rejections, maybe are associated by the renal or vein thrombosis, which you need to work with the adequate IV fluid, maybe something you give now the thrombolytic drugs.
Okay, I think we'll finish the discussion there. Thank you again, Dr. Syriac, for this very interesting and informative presentation on chronic kidney disease in children. So I'll just let you finish off with a few take-home remarks, and then we will close today's session.
So thank you, Dr. Academia, to give me this opportunity. So I've been trying to be advocating for the children as I can, and also I request other people to advocate for the children. So for the clinician, once you find any child with the small elevate of the creatinine, or even once you do creatinine levels, always measure estimated glomerular filtration rate. If you found it abnormal, it's better to refer to the nephrologist earlier than to keep the child in local areas. So screening for the KOB utterance for all the children who present to you nitrite infection more than twice. So screening for hypertension for any children who attend any clinic, because we found also there is severe hypertension in the children, and usually is undiagnosed, where the people they say maybe the child has headache or heart conversion is mistaken by the meningitis, or maybe a hypocalcemia. So let's work together. For the one who can have advocacy for the big politician, you can advocate for the children at least to have adequate care, and the benefit for hemodialysis and peritoneal dialysis, which is supposed to be paid by NHIF if it's possible. And of course, hopefully we are able to do many transplant children maybe in the future, and in God we trust. Thank you so much.
Thank you, Dr. Syriac, and thank you, participants, for attending today's session.